Femur, you know now much more than me in the femur. Okay. Then we did the thigh. Thigh has anterior compartment, is a medial compartment. Anterior is quadriceps femoris. Quadriceps femoris, not quadratus. Quadratus femoris on the back. Then we have the medial compartment, which is composed of adductor longus, adductor brevis, adductor magnus. Okay. And then some part of yes. On the back there are three basic muscles. This group is called hamstring muscles. Hamstring muscles are three basic muscles which are really on the back, and one adductor magnus which is peeping into them and considered as one part of hamstring. So they are semimembranosus, semitendinosus, biceps femoris with two heads, and then there is adductor magnus, which is called as hamstring part of adductor magnus. Am I clear? You know this already. Okay? All of you know this. Then what we did, we revised some movements. Why I am doing movements again? Just to quickly revise, so that when you are dealing with the muscles individually at your home, you may be able to deal with the movements individually. Okay? So, avalan, the movements of the hip joint. This is standing posture. Standing posture means both the gluteus maximus, they are contracted or relaxed? Contracted, because gluteus maximus is the chief extensor of the thigh. Okay? Then flexion of hip joint, or if I wish to do very close flexion, this is flexion towards my chest. So this is again a flexion. This is the start of flexion, and here I am flexing both the knee and the hip, but here I am only flexing the hip. Understand? I will come in the center, no problem. Don't move it. Okay. This is what we know about flexion. Then there is extension of the hip joint. Then there is abduction of hip joint. Then there is adduction of hip joint. Then there is medial rotation. For medial rotation, we can do it like this, but it is not very appreciating. Okay. Flexion of hip, extension of hip, then there is abduction of hip, then there is adduction of hip. Okay? Then there is medial rotation. Medial rotation I can do like this or like this. But to appreciate it more and see the more movements in range, I flex my knee and then I make it a very good medial rotation, central, and then a lateral rotation in both. This is regarding the movements of hip. Then there is a circumduction. Circumduction is always known as combination of movements. Maybe two, more than two, or all of them, they are involved. This is circumduction. Then regarding the knee, I told you there is flexion of knee, then there is extension of knee. Knee is a hinge type of joint, but it is modified hinge. We do have a small degree of rotation, which will be dealt with you in case when we will deal with the knee joints especially, and the locking and unlocking mechanism. One of the group which I took the lab today, they know something about locking and unlocking, but wait, it's not a necessary thing at this point. Then what we did here is as thigh. Then I introduce you the fascia of the thigh. Then I told you there are two types of fascia in the thigh: superficial fascia, deep fascia. The superficial fascia, like not other parts of the body, has two layers here, and they are fatty layer. Then another is membranous layer. The membranous layer is very much attached to the deep fascia. The deep fascia has same cuff or sleeve-like structure, which is holding whole of my thigh, with only two very important areas. It is thick, but the thickest part is on the lateral aspect, which is called as iliotibial tract. What is iliotibial tract? It is a 2 inches tract which is from lateral side, extending from lateral to lateral. It has two parts here, two bifurcations, which shows you insertions, attachment of this iliotibial tract to the hip joint, capsule, and another for the ilium bone. Two of the muscles they insert into it: gluteus maximus partially and tensor fascia lata. What is tensor fascia lata? The name is self-explaining, that the tensor fascia lata makes the fascia lata tense, so that when I am moving or I am moving in a partial flexion, especially in the partial flexion state of my knee. This is full flexion of knee. This is partial flexion of knee. When I am moving or running in partial flexion, this iliotibial tract stabilizes my knee joint. This is what we did. Then after that then we did something about the femoral triangle. What is femoral triangle? Femoral triangle is let us come to the femoral. One thing I forget here. This is called saphenous opening. One of the students asked me, so I can repeat. This is actually the saphenous opening. It is not as such a big opening like this. It is still covered with a small fatty layer, which is called, or a fascia, which is called cribriform fascia, which has small maybe holes or no. And the vein alatul comes here and enters into it. Enters where? Here is another vein crossing. This is femoral vein. This is great saphenous vein. So this will drain into this femoral vein. Okay? Then we did about the compartments. You know the muscles, you know the movements now. If you still have any queries, later on we can discuss, no problem. Then we did Yes. Regarding the femoral triangle is, don't try to find femoral triangle is a surface depression, like a cubital fossa, like my popliteal fossa. This is a surface depression on the upper part of medial side of the thigh. And you know the boundaries, inguinal ligament. You are aware of the inguinal ligament, that it is the terminal part or thickening part of one of the abdominal muscle, external oblique. It is attached like this here, anterior superior iliac spine of the hip bone, anterior superior iliac spine of the hip bone to the pubic tubercle of the hip bone. Here is the attachment of inguinal ligament. Okay, so inguinal ligament is attached like this, like this. Then this is one boundary of this is one boundary of femoral triangle. Then there is another sartorius. Then there is adductor longus. If I go deep, if I remove the skin, this is actually the roof. If I remove the skin, go deep into, then I will see a group of muscles. Adductor longus, then pectineus. Then I will see iliacus and psoas, or collectively known as iliopsoas, which makes the floor of the triangle. Then we discussed that there is another structure which is called as femoral sheath. What is femoral sheath? Femoral sheath is a sheath which is made by two fascia of two muscles. Here is one muscle, here is another muscle. Both of them, they are covered with by their fascia. Fascia transversalis and iliaca here. So both of them, they have fascia. When both the fascia, they unite, they make a sheath like this. And the sheath is funnel shaped. Okay, Keith. And then if you observe the sheath, it has compartments. Now I will start with the compartments of the sheath to refresh your vision again. Yes, I'm here now. Are all of you with me?
Yes.
Good. So this is actually the femoral sheath. Where what area is this? I'm showing you. I'm showing you this part actually. I'm showing you this part. Okay. So this is
Anterior.
Yes. And if I make it anatomical position, how it is in my body? It is in my body. It is like this. So it's like a jib pocket here. Okay. So remember, like a pocket with three openings. How the openings are made? This is made up of connective tissue from one muscle, another muscle. They have compartments, special areas for passage of special structures. Like femoral artery, in the most lateral, I make it lateral, anterior, posterior, medial to make your life less miserable. Then femoral artery with genitofemoral nerve, femoral vein, here is a special area. This most medial compartment of this sheath is called femoral ring. So you know femoral triangle, you know femoral sheath, you know femoral ring. What is femoral ring? This is actually femoral ring. If you say, if they ask boundaries of femoral ring, so boundary of femoral, what is femoral ring? It is the most medial part of the femoral sheath, which is bounded by one side with one compartment of the sheath. On the other side, there is a special small ligament known as lacunar ligament. Then In the front, in the back, it has pectineus muscle with pectineus fascia, and here is the inguinal ligament. This is the actual demarcation here of this structure. Okay? The most medial part here, the most medial part is here. It contains some amount of fat here. The sheets, all the sheets, never think they are like open like this. Definitely there is fat to support the structures. So here is some fat. In the fat there is one or two big lymph nodes usually, which are there to drain the tip or the glans penis and the clitoris in females. If there is inflammation of these structures, it will enlarge. This lymph node has two names. Lymph node of Cloquet, or the other lymph node, the name is Rosenmuller lymph node. Rosenmuller node. Here you can see. The clinical importance of this femoral ring is that in females the ring is bigger. Why? Because of broad pelvis. Okay? Because of the broad pelvis, the ring is bigger. And there is more chance for females to develop femoral hernia. So all, remember all F. Females, femoral hernia, femoral ring in the femoral sheath. Okay, so all F's, and be aware of them. This is the femoral ring. Now think, this is femoral ring. And now the herniated part is going into the ring, and then when the sheath is finished, it will come, and since it is intestinal or soft tissue, it will move front. This is the pathway of hernia, femoral hernia. Very common in females, not common in males. Males, they have inguinal hernia, okay? Because the inguinal canal in male is different as compared to this. So this is the direction of femoral hernia. And when you will become a surgeon and try to reduce this hernia, try to reduce, don't push it back, push it down, because the pathway is down and then it will come inside. So this is the way, this is the clinical importance of femoral sheath in the femoral triangle, and it has the most medial compartment known as femoral ring. Am I clear at this point? Okay. Yes. This is actually the femoral hernia. This is the appearance of femoral hernia. Okay. Now I start with another topic, adductor canal. What is adductor canal? It has three names. Adductor canal, subsartorial canal, or Hunter's canal. Okay? It is an intramuscular space in the middle 1/3 of medial part of the thigh. Here. This is the space. You don't find anything on the surface, okay? Like this. If you examine a patient, you will not find anything. You will just find a triangular depression for femoral triangle. And after you imagine, this is your imagination, takhayul, that the tip of this will continue into a subsartorial area, subsartorial canal. Why I say subsartorial? Very easy to understand, because sartorius muscle is covering and the canal is underneath. Okay, this is subsartorial canal, so it is easy to remember. Subsartorial canal. Then, what is this actually? It is from apex of the femoral triangle, till it reaches another opening here. I told you there is another opening, which is known as hiatus magnus. Now you know adductor magnus muscle. Adductor magnus is a very broad, short stop of a muscle, which is not only موجود on the adductor compartment, rather some of the fibers are going back, and when we label this as hamstring part of adductor magnus. It has small openings, 1, 2, 3, 4, some books says 5. The largest is at the lower end. This is called hiatus magnus. All of them, they are called hiatus. Adductor hiatus or hiatus. The biggest one is on the lower part. This is called hiatus magnus, the biggest opening. This is the end point. So here is the opening. Okay, so the subsartorial canal is extending from tip of, or the apex of the femoral triangle till it reaches hiatus magnus. What is hiatus magnus? You know now. What is the function of this hiatus magnus? The femoral artery, which is entering from here, will reach the cross the whole of the femoral triangle. Of course in the sheath, then it will leave the sheath, cross directly into the femoral triangle until it reaches the apex. Then it will reach into the space which is called subsartorial canal or Hunter's canal until it reaches the hiatus magnus here. So once it reaches here, it has an area to go back. So from here it will go back and continue on the back as popliteal artery. So same femoral artery continues as popliteal artery after this. What happens to popliteal artery here? This is femoral artery, this is femoral triangle. Here is the femoral artery in the subsartorial canal. It will reach hiatus magnus. Now it is called popliteal artery. Once it reaches in the popliteal fossa, it will divide into many branches for the knee. We will deal it today. After that, it divides into two main branches. With, you remember interosseous membrane here?
Yes.
Similar interosseous membrane is موجود here between tibia and fibula. Here is tibia, here is fibula, there is interosseous membrane. So between them, this anterior tibial artery will cross in front and posterior tibial artery will go back. So think like a sheet like this between my tibia and fibula. So here is the popliteal artery. Now it will divide into anterior tibial and posterior tibial. The anterior tibial will cover all the muscles and bones in front and lateral aspect of my leg, and the posterior will cover the posterior. The anterior will continue as some artery on the foot, on the dorsum. This is called dorsum of the foot. And the back one will reach the plantar surface of foot. Foot has two surfaces, dorsum and plantar. Are you with me?
Yes.
I think I'm not going very rapid. I'm trying to give you pieces of knowledge from everywhere to make a very comprehensive picture in your brain. Okay. Now, this is about the femoral artery. What about the femoral vein? This artery has a connected anterior tibial vein. It has a posterior tibial vein. Both of them, they will unite, make popliteal vein. Then popliteal vein will cross the same opening and continue as femoral vein. Are you with me?
Yes.
So this is to describe like, okay. Now again back to the subsartorial canal. Here is the canal. If I open it, remove the skin, what I will see? It is a triangular structure. This musculus. Okay, this musculus is a triangular structure under cover of which muscle? Sartorius. So this is sartorius. So under cover of sartorius muscle. So this is sartorius. On one side, here is sartorius. On one side, this is vastus medialis. So this is vastus medialis. And if I go deep, what is under? Is adductor longus and magnus. Both of them on the deep. So this is a picture which is showing you the actual cross section level of adductor canal. Subsartorial canal or Hunter's canal, same name. Better to remember as subsartorial because you will remember the relations. Sartorius is on the top. Okay. What are the contents? Femoral artery, femoral vein. Now you know from where the femoral artery is coming, how it is formed. Now you know femoral vein, how it is coming, from where it is formed. Saphenous nerve is one of the nerve in this. Obturator nerve. What is obturator nerve? Obturator nerve is a nerve running in the obturator foramen, which is there to supply the adductor compartment. Adductor longus, brevis, magnus, and the hamstring part of adductor magnus as full. And then some muscles here like pectineus or some. We will repeat all these nerves in the lecture of nerves. All the nerves we will take and we will take the branches. Hopefully I will come. Inshallah. Okay. Anything unclear now? Yep.
The femoral triangle is above the inguinal ligament or after the triangular, the femoral triangle?
Again, see this one. See, here is the thigh. Here is the thigh. Here is the knee. Okay. Where is the inguinal ligament? Anterior superior iliac spine to pubic tubercle. So this is one boundary of the femoral triangle. Then here is adductor longus. So So this is another boundary. And here is sartorius. So here is the third boundary. So this is femoral triangle.
Okay.
Khalas? Inside the femoral triangle, there is femoral sheath with 3 parts. And I told you it's like this. Here is the femoral ring. And after the femoral artery is crossing here, it will reach, and here is the subsartorial canal. It will raise the magnus, hiatus. It will go back. Now clear?
So the sheath is within the triangle.
Sheath is within the triangle, but it is not covering the whole of the triangle. How it is covering the triangle? Here is the triangle. The sheath is like a funnel shape. You know funnel? Funnel. So here is khalas. This is the end point of sheath. But if you try to imagine 3D picture of this, here. So here are the compartments. So here the femoral artery will come and cross like this. Now clear?
Yes.
All of you? Yeah.
So the apex, the sartorius is above the fingers.
Yes, they are like this. Sathai and amik. They are superficial and deep. Sartorius is the first muscle I can see here. If I remove sartorius, if I remove everything, if I remove the canal, go deep tahat, I will find adductor longus and magnus. They are crossing like this.
So he asked about the apex.
If he asks about the apex, here is the apex. Here is the base. Okay, when he asks about the boundaries, so try to remember the boundaries. I have a special slide for it. You can read. Anything mushkil here now? Good. Okay, sciatic nerve. You have some idea of sciatic nerve.
Yes.
Okay, where is sciatic nerve? Now this is front of the thigh. Forget it. Now I'm drawing here, trying to draw here the back. Here is the gluteal region. Here is the thigh. Okay. Here is the sacrum and coccyx, and here is the start point of the nerve rootlets. What do you know about the sciatic nerve? Sciatic nerve is the largest and thickest nerve in the body. Thickest. Don't think longest. Okay? Thick. The thickest nerve in the body you can very nicely appreciate. We will try to appreciate you on the cadavers. It is 2 centimeter wide even. This much wide. It has 2 parts. Tibial nerve and common peroneal nerve. Forget these 2 parts at this level. Try to know the formation of the nerve. You remember when we teach you brachial plexus, there is anterior primary ramus of C5, 6, 7, 8, T1. Now here, both the rami, anterior and posterior, both of them take part in the formation of sciatic nerve. So, anterior primary rami and posterior primary rami. L4 to S4. Remember, L4 to S4 means L4, then L5, then S1, S2, S3, S4. So all these branches will contribute in the formation. Once they make this nerve, especially the part which is anterior will lead to formation of common peroneal, and posterior will make tibial nerve. How? Okay, stay here. Here is the formation of sciatic nerve. Okay, in the gluteal region. It is crossing. Here is the ischial tuberosity. What is ischial tuberosity? On the hip bone here. All of you now, you are sitting on your ischial tuberosities. So when I sit, the ischial tuberosity is on the base like this. So all of we are sitting on the ischial tuberosity. So between the ischial tuberosity and now you know some idea of. So here is the ischial tuberosity. Here is the greater trochanter. Just in between them, it will cross. So here is the ischial tuberosity. Here is the greater trochanter of femur, and now the sciatic nerve will cross between them. It will go down until it reaches the knee area, where we have a special structure which is called popliteal fossa. What is popliteal fossa? It's a depression which is visible on the back of the knee. When I examine the back of the leg, you will find a depression like this. This is called popliteal fossa. This is like a diamond shape. Okay? This is like a diamond shaped fossa on the back. When the common peroneal, this sciatic nerve reaches the upper level of popliteal fossa, it divides in 2. One goes down tahat alatul and one makes a lateral turn. This branch is called tibial. This is called common peroneal. Actually, we know these branches from this point. But for the formation of these two, the anterior rami will continue as common peroneal, contribute, and posterior will contribute into the tibial nerve. Am I clear up to this point? With me? Good. Okay. Course and relation. Now very easy thing starts. Sacral plexus in front of piriformis. You know the piriformis muscle is in the pelvis and on the gluteal region. Greater sciatic foramen between greater trochanter and ischial tuberosity. I told you it crosses the thigh, superior angle of popliteal fossa. This is popliteal fossa. This is called superior angle. I told you it's a diamond shaped space. So here is the superior angle. So at the superior angle, it will divide into two branches. One will go ala tool straight down straight tibial nerve. One will take a lateral turn. This is called common peroneal nerve. Tibial nerve will follow the posterior tibial artery and vein and go down and supply all the muscles of the leg. The lateral one, which is common peroneal, will cross here, remain superficial with fibula. Here is a bone fibula, and then it goes down. It supplies muscles on the front and lateral aspect. We will deal with the nerves, no problem. Okay, this is just an overview. So here is the sciatic nerve, here is the posterior tibial nerve, and here is the common peroneal nerve, supplying the group of muscles, which we will deal later on, no problem. Okay. Branches of sciatic nerve, articular branches. What does articular branches mean?
To the joints.
To the joints. Remember one thing in the world. Any nerve which is crossing a joint must give a branch to the joint. For example, here is the elbow joint. How many nerves are crossing here in this
Three
region?
nerves.
Median nerve, ulnar nerve,
radial.
radial nerve. So all of them, they will give the branches. This is a law called Hilton's law. Hilton's law. Hilton was a scientist who described that every joint which is crossed by a nerve must be supplied with a nerve. Why?
Because it crosses.
Very good. The nerves which are on front of elbow, for example, they are there to supply the muscles flexor region. They are here to supply the muscles of extensor region, the radial. If the flexor nerves are, now the movement of this joint is like flexion and extension. Both the muscles group should have information that it is now flexing, and they should allow to flex it. Otherwise, if this remains contracted, the flexors will fail to flex it. So information goes to both, let the joint flex, so flexor will flex it. So this is the practical point of this joint. Agree now?
Yes.
So it's just not only the crossing. It's crossing and the information.
Muscle attach.
Yes. So articular branches to the hip joint. Is it crossing any other joint? Yes. Once it is crossing the knee, if this is common sciatic, it will give branch to. But usually, I told you at the angle here, it divides in two. So sciatic will not give a branch, tibial will give a branch, and common peroneal may also give a branch to the knee as per rule of Hilton's law. With me? Okay. Tibial part in the thigh, semitendinosus, semimembranosus, and biceps. Plus, these are all hamstrings. These are true hamstrings, semimembranosus, semitendinosus, and biceps femoris, along with adductor magnus, which has ischial part or ischial head, which is known as hamstring. So all the hamstring muscles, they are supplied by this. Then, common peroneal in the thigh, it will supply biceps femoris, short head. Common peroneal injury, sciatic nerve, compression or common site of injury. When you are standing on an edge, like here, after some time, you start tingling sensation, needles and pins in your foot, because the nerve is being compressed. Okay? When there is a partial compression of any nerve, sometimes you are dealing with your mobile phone and your hand is on the bed while you are lying in the bed in the night. The ulnar nerve got compressed and you feel some anesthesia or tingling like sensations here. So this is the same, this is called sleeping foot. Penetrating wounds in the gluteal region or bullets can damage or intramuscular injections. When we teach you intramuscular injection, we said that this is the gluteal region we must divide line of takhayyul in 4 compartments and we must
Upper
inject
left.
here. Agree?
Yes.
Why? Because if you inject here or here or here, there is a chance to damage the sciatic nerve. So always select this compartment for intramuscular injections. Wrong intramuscular injection with junior students can damage this nerve and can lead to injury. Effects of injury: hamstring paralysis. Surely it's supplying all the hamstring, they will be
No
paralyzed.
flexion of knee joint.
What is the effect? Weak flexion of knee. Why we say weak flexion? It must be absent flexion. No absent, because knee is supplied by femoral and obturator both. So all those muscles which are followed by obturator, they are alive. They are still good. So partial flexion of knee is possible. Foot drop, all muscles below knee are paralyzed. What is foot drop? What is wrist drop? Awalan?
Like this.
When there is a radial nerve damage, you cannot hold the wrist and it hangs like this. This is called wrist drop, radial nerve damage. So here, the foot drop is because of injury of sciatic nerve. Am I clear?
Yes.
Good. Sensory loss. Below the knee except saphenous nerve. This is all supplied by the sciatic except saphenous part. So this will be good. All other surrounding area will be numb. No feelings, no sensory areas. So this is the way of injury here. Some books say alam nisa, some books say arkan nisa. This is when it is involved here in this region. The pain is going all in the leg, on the back, sometimes even to the heel it is felt. All this distribution is the sciatic nerve and this is called arkan nisa. Why nisa? It's common in females. No, it's not common in females. You forget everything, it is from nisyan. It is not for nisa, okay? The arkan nisa is from the nisyan. You forget everything once you have this pain. This is one of the Arab scholars told me. I'm not sure, I didn't read anything, but he told me, so I conveyed to you.
He's trying to open conversation. It's not true.
It's not true?
No.
Okay. Common peroneal nerve, we will deal with the leg. So forget it now for this time. And common site of injury effect, okay, leave it. Leave it. Leave it. Yes. Popliteal fossa. We will cover this all in the nerves, okay? Don't worry. I will, if I am there, I will cover. If anyone else is there, they will cover. Don't worry. Popliteal fossa. What is popliteal fossa?
A diamond shape.
A diamond shaped space on the
region.
back of the knee. Okay, this is diamond shape. The boundaries are called as superior lateral, inferior lateral, superior medial, inferior medial. Okay, if this is the knee, this is the popliteal fossa on the right side. So lateral, superior lateral, superior medial, inferior medial. This is a diamond shaped space which is visible on the back of the knee. This is called popliteal fossa. It is actually an intramuscular space, intermuscular space. What are the boundaries? Try to see this figure. This is the region of thigh, back of thigh with hamstring muscles, and this is the region of leg. In the leg, I'm sure you have not done with the leg, so just a quick information about, here is the gluteal region, here is the thigh, here is the popliteal fossa, and here is the leg. Clear?
Yes.
So, in the leg, when you feel here, you feel a very bulky muscle. This muscle is called gastrocnemius. It has two heads, one here, and you will feel the bulk in your thigh. This is called gastrocnemius. Plus there are some other muscles, plantaris, and you will deal in the leg. For this, okay, here semimembranosus, semitendinosus, and biceps femoris. So all these muscles are here. Try to find how they are arranged in the fossa. Semimembranosus, I am talking of this superior medial boundary now. This boundary. Superior medial boundary, this line is made by semimembranosus, semitendinosus, gracilis, sartorius, and adductor magnus. All of them, they are crossing here. Then biceps femoris on this side. Which side? Suprolateral. Then gastrocnemius, this bulky muscle, has two heads, I told you. A medial head, a lateral head. So medial head will make
The
the
inferior
inferior medial boundary, and the lateral head will make inferior lateral boundary. There is a small muscle crossing here. The name is plantaris. So in the leg. So these are the boundaries of popliteal fossa. Any question? Like cubital fossa or like femoral triangle, we are dealing from the anterior aspect. Here we are dealing from the posterior aspect. Okay? But still the roof is skin, superficial fascia. Don't think the popliteal fossa has roof here. No. Yani knee and no. The knee is the deepest part in the fossa. Understanding my point?
Yes.
Okay. So the roof is skin. Remove the skin, superficial fascia. After superficial fascia, there will be deep fascia. The superficial fascia contains these structures. Then there is deep fascia, like routine deep fascia on every part of the body, like deep fascia. Then, if I remove skin, superficial fascia, deep fascia, I will see what is inside. Inside there is floor. Floor is made by femur. Now, which part of femur? Here is the femur.
Inferior.
The group which has not taken the lab, I will repeat for them. This is the anatomical position of femur. Okay, this is the anterior aspect. This is posterior aspect. On the posterior aspect, you will find this triangular area. This is called popliteal surface or popliteal area of the femur. So this is actually, now can you appreciate the diamond area here? The upper tip of the diamond. So this is approximately facing the same diamond part of. So femur, popliteal surface. If I still go deeper, I will find capsule of the knee joint. I will open. I will reach into the knee joint, and then I will reach the popliteal fascia, which is surrounding the popliteal muscles. These are making the floor of the popliteal fossa. Very easy. Popliteal fossa is not a difficult thing. Very easy and like a gift question. Okay. This is the same popliteal fossa showing you the popliteal surface of the femur. Here is the back surface of tibia. Here is fibula. We are still remaining with tibia and fibula. Next week I will take tibia and fibula both together with you. A time is near when you will start hitting my face. This man is everywhere. So please forgive me. Contents. What are the contents of the fossa? All those structures which are crossing or mojood inside, they are called the contents. So, popliteal artery and its branches. Now you know what is popliteal artery? How it is formed? It is the continuation of femoral artery. After hiatus magnus. So after hiatus magnus, popliteal artery and its branches. Wait, we will see the branches. Popliteal vein and its tributaries, rava afid. Popliteal vein. How popliteal vein is formed? You know now. No, it will continue as femoral. Here, anterior tibial, posterior tibial, they will join, make popliteal. Popliteal will go follow the popliteal artery until it reaches the hiatus and will continue as
femoral
vein. Clear?
Yes.
So, popliteal vein and its tributaries. Tibial nerve is a branch of sciatic going alatul is tibial nerve. Common peroneal nerve going towards the side. I told you, you can feel the peroneal nerve here. On the lateral aspect, there is a bony part. This is called fibula. Lateral aspect, not medial. Lateral aspect. Lateral aspect. There is a fibula. There is fibula. The head and neck of fibula. It is crossing on the neck. This is the neck of fibula. It is crossing on the neck. So you can feel. And sometimes you can have an electric current like ulnar. Sometimes if you cross near a chair, you have a touch to this nerve, you will feel an electric sort of, and you remember how to remember it. It's like death of the wife. It hurts you very rapid, but you forget it very quickly. Okay. Posterior cutaneous nerve of the thigh is a branch from sciatic. Genicular branch of obturator nerve. Genicular means knee. Geniculum, knee. Popliteal lymph nodes and some fat. These are the contents of popliteal fossa. These are the contents. Can you appreciate at least few structures? Can you appreciate the boundaries now? Superior superior medial, superior lateral, medial, inferior lateral. What are the muscles here?
Bicep femoris.
Yes.
Okay. Here
One head. Then
semitendinous.
semimembranosus, semitendinosus, bicep femoris,
Sartorius,
and gracilis. Here, bicep femoris.
with the two heads.
Yes. Here, the gastrocnemius one head, gastrocnemius with plantaris another. See the contents. Popliteal artery, popliteal vein, then nerve, tibial nerve. The artery is the deepest structure in the fossa. Okay? When I say deepest, means there are three like this.
So it's
Okay?
near the knee.
So near the knee. When I say deepest, don't think it is on the skin. No. It is towards the knee. So that is the reason whenever you deal with the popliteal pulse, when you have done physical examination of pulses, you used to go very deep and still you are unable to find it. Okay? So this is the reason. In nearly the notch, so you have to put your, there are a lot of muscles surrounding. So you have to relax them and then you have to go deep to find the palpation of popliteal artery. Then you can see here popliteal nerve, popliteal vein, and you can see here tibial nerve with common peroneal nerve. One of the beauty of these two nerves, they have a common branch here. This is called sural nerve. Sural nerve is a common branch is a branch partially, like you remember here, median root of median nerve, lateral root of median nerve from two cords, and they make a one median nerve. So this sural nerve has one contribution from tibial, one contribution from peroneal. It is called sural nerve. Yeah.
Posterior cutaneous.
Posterior cutaneous. Cutaneous means posterior cutaneous is here, giving cutaneous nerve supply to the leg. Posterior cutaneous nerve leg. Okay. This is just a quick revision. There is nothing special here, except we have to see the branches of popliteal artery. What are the branches? Can you see this anastomosis around the knee?
Yes.
Remember, all the joints, they have anastomosis around them. Why? Yeah.
Because of the capsule.
Because of the capsule. Capsule needs, there are a lot of muscles inside the joint, attached to the joint and acting on the joint. They need a good blood supply. Excuse me.
But also there is no arteries inside the capsule.
There is no artery. They are called articular branches. That is the reason they are called articular branches. The articular branches are supplying the capsule. So, anastomosis around the knee joint is very important and is contributed by, appreciate this popliteal artery after the hiatus. Popliteal artery up till it divides in two, and I told you there is interosseous membrane with anterior and tibial artery, posterior tibial artery. Now, these are called genicular branches. There are 5 genicular branches. Can you appreciate 1, 2, 3, 4 and the 5? Okay? 1 medial, superior lateral, inferior lateral, superior medial, superior lateral, inferior lateral. 4 and 1 is going deep like. Now think, this is the back of knee joint. Here is the popliteal artery crossing. It will give 2 branches here, then 2 branches tahat, and 1 branch will go inside alatul, the knee area. Knee joint capsule it will supply. So these are remembered, we label them as 5 genicular branches of popliteal artery. Of course, they are making anastomosis around the knee in front like this. With me?
Yes.
I think you are not, I'm not boring you.
No.
You are with me? Good. I'm finishing around. Yes.
Are the branches part of the popliteal fossa?
No. We usually say the content is popliteal artery and vein. The branches are just spreading out of it. There may be variations. Forget them. Don't even read about it. This is the same back. Just to review, yes. This is the review of sciatic. This is the gluteus maximus, partially cut to show you the inside. Here is the piriformis. You remember the key of this region is piriformis. anything above the piriformis is superior gluteal artery nerve, inferior gluteal artery nerve. Here is the sciatic nerve, and here is the skill tuberosity, greater trochanter. It is crossing in the middle of them, and then it crosses down alatul until it reaches the upper diamond part of the upper angle of popliteal fossa, where it divides in two. The common tibial goes alatul taha and common peroneal. Clear?
Yes.
I am repeating many things just to reinforce the knowledge. This is the superficial vein here. We will deal with the leg, no problem. Nothing important. Only about the lymph nodes, because there are certain lymph nodes in the popliteal fossa as well, like there are lymph nodes in the axilla. Okay. The deep feeling of popliteal artery. When we say deep, it means it is not towards the popliteal fossa roof. It is deep into the tibia and fibula and femur. So it is very deep to feel it, popliteal artery. When we make dotted line, it means what?
Behind.
Behind. So here is the femoral artery, hiatus magnus going behind as popliteal artery, coming in front as anterior tibial, behind as posterior tibial. Like we check blood pressure in the upper limb, we check the blood pressure in lower limb with the help of popliteal artery, if the limbs are not functional or not there. Injuries, popliteal aneurysm. What is aneurysm? Aneurysm is ballooning or dilatation of an artery. This is called aneurysm. Popliteal aneurysm is common. The reason we don't know, but the popliteal aneurysm is common, so you have to be careful while examining the popliteal. There can be cysts arising from the knee or other structures. These are called popliteal cysts. You can use popliteal as ultrasound to know about the flow of, if the lower limb is having gangrene and you are expecting a less flow in the limb, this is one of the typical arteries to monitor. And here is, yes, in the thigh, I don't find in the objectives that you need the cutaneous nerves and vessels, or no, in the objectives. But still I write here, if they are in the objective, please follow the objective. If they are in the objective, please read from here. If they are not in the objective, okay? So all what I told you today and in the previous lecture, everything is
Here.
labeled. I labeled it for you to make your life
Less miserable.
less miserable. It is already miserable. I'm trying to make it some less. Give you some comfort, okay? So all the branches, their names, blah, 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 blah. Thank you.